Okay, that sounds good. So we will call the interim meeting of NCOIL Health Insurance and Long-Term Care Issues Committee to order. Will, if you'll take a roll call, please.
Sure, thanks, Mr. Chairman. We'll start with committee members who I either see or have registered for the call. Arkansas Representative Deborah Ferguson.
Here.
California Assemblyman Tim Grayson.
Here.
Connecticut Representative Tammy Nuccio. Illinois Representative Camille Lilly. Louisiana Representative Edmund Jordan.
Here.
Montana Representative Nellie Nickel. New York Assemblyman Jarek Gandolfo.
Here.
New York Assemblyman David Weprin. Ohio Senator Bob Hackett.
Here.
Oklahoma Representative Ellen Hefner. Utah Representative Jim Dunnigan. Okay, we have Chair Westfall.
Yes.
Okay, going to non-committee members who have registered. Arizona Representative Lisa Sun.
Here.
Massachusetts Senator Michael Moore. Maine Representative Poppy Arford. Kentucky Representative Jim Gooch.
Here.
Oklahoma Representative Forrest Bennett.
Here, and also Representative Hefner's father passed away a couple days ago. Otherwise, she would be on the call.
Very sorry to hear that, but thank you for telling us. South Dakota Representative Carl Perry. West Virginia Delegate Mike Hornby. Okay, I do see Minnesota Senator Paul Utke is here. Are there any other legislators present that I did not call?
Representative Rachel
Mississippi
Roberts.
Senator Walter Michelle on audio only.
Yeah,
Representative
I saw
Camille Lilly.
Representative Camille Lilly, Representative Rachel Roberts, Senator Walter Michelle. Anyone else?
Yes, Representative Poppy Arford, but I will be off video.
Thank you, Representative. Anyone else?
Representative Carl Perry.
Thank you, Representative. Okay, I think that's it. We'll just need a motion to waive the quorum requirement, Mr. Chairman.
Yes, do we hear a motion to waive the quorum requirement?
So moved, Tim Grayson.
Do we have a second?
Second, Rachel Roberts.
Deborah.
Okay, all in favor say aye.
Aye.
All opposed? The ayes do have it. The quorum requirement is waived. Good afternoon or good morning for those in other time zones. So thank everybody for joining the meeting today. I know everybody's very busy and I appreciate you participating today. While there's only 2 items on our agenda, I anticipate that each will generate a lot of discussion. Let's get right to the business. We'll begin with the continued discussion what I refer to the NCOIL DLR model, a model which I sponsor and Illinois Representative Rita Mayfield is co-sponsoring. There won't be any votes on the model today. Rather, we'll be discussing some alternative language that has been circulated and we'll be hearing from new perspectives on this issue today. We'll then discuss the proposed federal rule that deals with certain issues such as short-term limit duration, insurance, and exception benefit coverage. So let's get started. First, we'll continue discussion on NCOIL DLR model. Begin with, I know Representative and President Ferguson have been working with some interest parties and staff trying to develop a compromise for all sides to accept, or at least something that leaves everyone a little bit more not rebellious. So I hope we can see the language within the next week. So Representative Ferguson, do you like to talk a bit about this a little bit?
Mr. Chairman.
I think I was okay as long as we came to some compromise language that's not just Colorado, but sort of Colorado plus some additional things.
Okay. So as you can see in the meeting material, a revised version of the models has been posted and generally following the approach that Colorado took with dealing with the issue. Instead of requiring a DLR and setting forth specific percentage, Colorado took approach of requiring carriers to submit a DL information to the commissioner. And after 2 years, the commissioner is required to issue rules to calculate an average DLR, identify any carriers that specifically deviate from the coverage DLR, and investigate the cause of the deviation. I'm not necessarily committed to replacing the current version of the model with this version, but I like to at least hear what the speakers today have to say, well, my fellow committee members. After today's discussion, I will discuss with staff how I'd like to proceed with our next meeting in November. So now let's hear from the speakers today. I note that other interested parties will be able to speak. We'll get started with the speakers first listed. First, we will have California Department of Management Care. Mary, are you there?
I am here. Hi, good morning. It's morning here. I'm not sure if we have the ability for Pratika Dutt, who is on, to share her screen. We do have a PowerPoint, so if Pratika is able to share her screen, we'd love to show you some slides. Oh, yay. All right, well, we'll hop right in here. So again, my name is Mary Watanabe. I'm the Director of the Department of Managed Healthcare. Pratika Dutt is with me today. She is the Deputy Director for our Office of Financial Review, which reviews our dental DLR filings. And it's an honor to be with you today to provide an overview of our requirements here in California for dental loss ratio reporting, to share a summary of the data that was submitted in 2021. We just received and are reviewing our 2022 data, so that'll be available probably publicly early next year. So just a quick overview of who we are. In California, we actually have 2 regulators, myself at the Department of Managed Healthcare, and then we also have the Department of Insurance. We license 143 health plans, including full service and specialized plans. We have nearly 30 million of California's 39 to 40 million consumers under our jurisdiction. That's about 96% of state regulated commercial and public health plan enrollment in the state. So big responsibility that I have. So the DMHC has been collecting dental loss ratio information since 2015. AB 1962 was signed by the governor in 2014 and required commercial dental plans to file their dental loss ratio information with us by September 30th, starting in 2015. To develop the template for reporting, we worked with our dental plans, associations, the Department of Insurance, and other stakeholders to develop the template and the guidance. The legislation was really intended to bring transparency. Prior to this bill, we really didn't know how much of premiums were being spent on dental services. And so it didn't establish a DLR requirement, but was really around transparency. It was intended to be considered by the legislature in adopting a dental loss ratio standard that would take effect no later than January 1st, 2018. However, to date, the legislature has not adopted a DLR. We do produce an annual report that we organize by product type. So you'll hear me talk a little bit about dental HMOs and dental PPOs. And we also look at the information by market type in the individual market, small group, and the large group market. We post this information on our website, which you can find at healthhelp.ca.gov, and we present it to our Financial Solvency Standards Board, which meets quarterly to advise me on financial matters. The next bill that impacted dental reporting was Senate Bill 1008. Was signed in 2018 and requires plans that cover dental services to use a uniform benefits and coverage disclosure matrix starting in January of 2021. This was really intended to bring transparency to consumers to compare plans, see what benefits were covered, to see what they're getting for sometimes their very low premium or more costly premium. Again, we worked with our Department of Insurance and other stakeholders to develop this matrix. We promulgated regulations. The bill did also require plans to continue reporting the DLR information, but it moved the deadline from September 30th to July 31st of each year to align with the federal MLR reporting requirements. Okay, so now I'm going to go over the results from 2021. And again, we'll start with the dental HMO products. So you can see here that in the individual market, the DLR ranged from a really low 5% to 81%. The weighted average was 61%. We had 14 plans in the individual market, 18 overall that offered dental HMO products. In the small group market, it ranged from 37% to 88% with an average of 50%. And then in our large group market, you see there 38% to 75% with an average of 63%. This next slide just shows kind of our trends since we started collecting the information in 2014. There hasn't been a whole lot of movement. You can see some slight changes, particularly in the small group market, but overall it's remained pretty consistent. And then this is the slide I think that is always of most interest. It shows the weighted average premium in our dental HMO market. In 2021, in the individual market, the average was around $11. Small group was $14, and in the large group was about $14.50. So these are fairly low premiums that in the dental HMO market. So next we'll go to our dental PPO plans. You can see here we had smaller number of plans, so 3 plans that offered dental PPO products. The 2 plans in the individual market had DLRs of 62% and 69% for an average of 64%. In the small group market, it ranged from 55 to 65% with an average of 57. And then in the large group market, DLR ranged from 57% to 88% with an average of 88%. There was very little change. Again, I think on the next slide, we'll show you the trends. We did, I will just note, have some outliers when we first started to collect this information. And I think the transparency helped to kind of move everybody to a little more consistency. So we didn't have as many outliers, which you can kind of see here in this chart. But overall, pretty consistent year over year. And then here, of course, the premiums in our PPO here, the individual market was $48 average, small group was an average premium of $50, large group was $42. So quite a bit difference from the smaller $14 to about $18 that we see in the HMO market. So that concludes our presentation. I mean, I hope it was helpful to kind of see some of the data. I will just note, we don't have a position on setting a DLR. I think the transparency has been really helpful to us. I think overall we can all agree of the importance of oral health, in overall health, and we want to make sure consumers understand what they're getting, even for those lowest premiums. The transparency has been very helpful. I'm sure you'll hear from plans and providers of kind of the pros and cons of setting a DLR. As we've had these conversations with our board and in public forums, I think one of the fundamental questions that comes up is just what is the value of these very low cost dental plans? And is there value to having some dental coverage versus employers, particularly small group employers or individuals, just not offering coverage? What does that mean for potential consolidation in the market? As you're well aware, unlike on the medical benefit side, we don't have a standard benefit design or mandated benefits. So it's different, it's complicated. I think we've had a lot of conversations with our board of just where to set a DLR. Is DLR the right measurement? So again, I think the transparency has been very helpful because prior to this reporting, we just didn't know how much of the premium dollar was spent on dental services. So that concludes my presentation. I'm happy to answer questions. Pratik is my subject matter expert and she can help me answer questions as well. But thank you again for the opportunity to be here.
Okay, let's hold questions until we get all the speakers, and we'll come back and basically any questions. Thank you a lot for your information. It's very helpful. Next, we'll hear from the American Dental Association and California Dental Association. First, we have Chad. So Chad, you there?
I am, Steve, and hello, everybody. And I want to thank the staff from California, the departments, for bringing that information to us. It reflects some of the previous comments I've made about things staying very similarly in terms of the DLRs that are reported. And that's, I think, the question before the committee as we keep considering the model is, do we look at this as an opportunity to change the value structure of the plans, which is something that DLR has the opportunity to do. So, but without further ado, well, and I'll say actually one other thing. We are pleased to be working with both Steve Westfall, Representative Ferguson, Representative Mayfield on something beyond, as Representative Ferguson said, concepts beyond just the Colorado language. So, but without further ado, I'm going to turn it over to Brianna Pittman. She is from the California Dental Association, and I get the pleasure of working with her often. So without me talking more, I'll turn it over to Brianna if you're there.
Hi, good morning. Thanks, Chad. And thank you, NCOIL members, for inviting us to talk. We have been looking at and thinking about and talking about MLR since 2014 when we worked on the legislation, AB 1962, and put that in place, and then sort of watching the MLR and trying to understand what it all meant. And I, really agree with Director Berry that the MLR data has been, I think, really helpful from sort of a policy perspective and understanding the market, and has given us a lot of insight. She showed you the weighted average, but the range. And so a lot of times we look at things like those weighted averages and they seem, fairly reasonable, 65%, but that really does hide that sort of huge spread. I think what you saw in the slides is that some of the trends seem to be that sort of the larger the plan or the larger the group, the higher the number. So large group products tend to have higher MLRs than small group, which tend to have higher MLRs than individual. But when you look at them individually, there are products and plans that have similar size that have very different MLRs, and there are high MLRs. So it is very clear that you can provide that value at a smaller scale. And I think we have some of the same concerns. Obviously CDA would really like to see a high threshold. We know that the medical MLR threshold is set at 80, 85, and sort of remain unconvinced that dental plans can't meet that, and think that that would be a good thing for patients. But those really low MLR plans are really concerning. What is that? I mean, is that actually a benefit? Is that a value? Is that just, if 5 cents of every dollar is going to patient care, is that a good use of somebody's dollars? When you get more into the, what's the right threshold? Is it 50? Is it 60? Again, CDA would like to see it higher. But I think even, an MLR below 50, that seems pretty low. How do we rationalize allowing consumers to spend money when they're only getting, less than 50 cents of every dollar back in value? And I think that sort of the wide range just really shows sort of the wild west of dental plans, that there isn't a standardized benefit. As much as I think we all sort of know how to use our dental plan, there really is this wide range. There's no standardized benefit. There's no cap on out-of-pocket expenses. There's a very low annual max. They're not really meeting people's needs. There's been a lot of studies to show out-of-pocket expenses are rising. We know that people skip dental visits because dental care is really expensive, even when they have dental insurance. So I think that for us, the MLR reporting has been really helpful in understanding and thinking through what are dental plans and what value do we think they should provide to consumers. It hasn't really, at least in California, moved the needle. We haven't seen sort of this rise in MLR over time. There's not a way, because of the way it's reported, it's not something consumers can use to make decisions about their healthcare dollars. So it's not driving competition. Not to say that's not good, but I think for us, it's useful. And in California, I think it was the very start of the conversation around MLR. So I guess my message would just be, don't make that the end. I think it's really helpful to look at and understand and think about dental plans. But I really believe that we need to be raising the floor on dental products, and that includes an MLR, but probably some other conversations around what the value is. Is there a standardized benefit? What do we think people should be getting to make sure they can take care of their dental health? And just would really encourage MLR to be part of that conversation. And I don't think reporting alone is going to get anybody where they want, and it's definitely not going to be pushing greater value. So I'll stop there, but again, happy to answer any questions on sort of what we've seen and how our thinking has evolved since 2014.
Okay, thank you. Before we go to the legislatures, do we have anybody else like to talk on this topic?
Yes, Delegate Westfall, this is Mike Adelbert from National Association of Dental Plans. I'd like to make a brief statement. So I appreciate your good work and the good work of the NCOIL staff and in considering this issue. I want to note that NADP is prepared to support a Colorado type approach, and that we view Colorado as a significant concession. There aren't very many industries that step forward and say, please regulate me more. We also note that while the Colorado approach is characterized as transparency or reporting, it's also reporting plus remediation. And so to Ms. Pittman's comments, they're appreciated. But if there are 5% plans and the regulator wishes to remediate them, this is a lever to do that. With respect to the Massachusetts approach, and whether there should be a medical loss ratio imposed on a much lower premium product. I just note that the news coming out of Massachusetts, I think is concerning. The department is late in finalizing its regulation. It was released, proposed reg was released a couple of days ago, and we think the department is struggling mightily and doing its best to ameliorate a difficult situation. But nonetheless, we think there are going to be some bad outcomes on January 1st. And today, I do want to announce and inform NCOIL that there are now 3 dental plans that will be leaving the small group market in Massachusetts. Guardian had previously made this announcement. Today, I can inform you that both Emeritus and Principal will also be leaving the Massachusetts market, and other exits are quite possible as dental plans look at the regulation and run the numbers and see whether they can, in fact, do business with a medical loss ratio, a loss ratio devised for a high premium product and applying that to a low premium product like dental. Regrettably, I think things are going to be tough in Massachusetts next year. We just wanted to make sure that NCOIL is aware of that, and we continue to be happy to engage in constructive dialogue, but do want NCOIL legislators to understand that we think the Colorado approach is already a significant concession on our part.
Okay. Thank you for the information. Do we have anybody else before we go to legislatures with questions or remarks?
Yeah, this is Jeff Album with Delta Dental of California, and just want to quickly buttress some of Mike's comments, but also as one of the dental plans that is heavily weighted in those figures that were just spoken about by the Department of Managed Healthcare and then addressed by the California Dental Association. I simply want to explain that the reason you do not see over time the loss ratio changing very much is because the market is what defines. Ooh, that was weird. The market pushes us to reduce our administration as low as we possibly can, as well as reduce the premium as low as we possibly can to reach the marketplace, especially in the small group and individual market. So if on these individual products specifically, what we have is that a loss ratio not actually measuring the savings that is generated to a customer because they are paying lower premium. In fact, you are penalized. The MLR penalizes your plan for lowering the premium to the customer, because as you lower the premium, the administration has to take a higher percentage of that premium. So if you really want to measure savings, and I did make this point last spring, and that's why I'll shut up very soon, let you carry on. As I explained to you last spring when we covered this issue, a lower medical loss ratio, a higher medical loss ratio dental plan can actually deliver higher savings to a customer than a lower medical loss ratio plan. The MLR is perverse when you apply it to a low premium product like dental. If you're only spending less than $200 a year on your dental plan, if you show up and get 2 dental services, cleanings, x-rays, all at 100% coverage in a 50% MLR dental plan, you're going to get $400 worth of services. You've already got your premium back plus some. And then if you actually need a filling or something else, the savings are more. So again, the MLR threshold is a perverse measurement that has nothing to do with the value of the product. And so I would strongly encourage you to go with transparency, as you heard from Mary. The transparency provides some value, and the remediation element of the Colorado model gives the regulator room to act when these outliers occur, and there's some other aspect to the story. Thank you.
Anybody else before we go to legislatures?
Steve, do you mind if I respond? This is Chad.
Go ahead. Yep, go ahead.
Okay, thank you. Thanks for the comments from everybody, including Jeff and Mike. Real quickly, wanted to point out a couple of things. One is what Jeff has just said is an admission that the value of dental plans is almost wholly based on the discounts they demand from providers. It is not about paying for care, and the payers. Again, just to educate the legislators, just to make sure everybody is clear, the true customers of these plans, in many cases, are employers and not the patients themselves. Just a reminder that Massachusetts passed with 72% of the vote because when patients heard the true value of the plan and how much was being paid for their care, they voted overwhelmingly for this policy. But keeping costs low for employers as the only gauge on whether plans are providing value is not proper. And so that I would push back on the idea that Jeff presented that this is a perverse policy. It is working on the major medical side, and it can definitely work on the dental side. Thank you.
Anybody else for good legislatures? Okay, do any legislature have any remarks or questions to any of our speakers? Anybody?
A little bit. Can I, this is Camille from Illinois.
Yes, go
Can
ahead.
you share a little bit about the rollout and how that went and the learnings from it?
Talking about California or Colorado or who?
Either one. It may be similar or both.
Okay, we have California on here, so who was it? You want it, Mary, or?
Yeah, no, I can take that. I mean, I think again, the probably the biggest challenge to the rollout was just developing the templates and the guidance for the reporting. So again, it wasn't a DLR requirement, it was just a reporting requirement. So we had a robust stakeholder process to make sure all of our dental plans, our provider associations, we worked with the Department of Insurance just so we could make sure we captured the information that would be helpful to just provide that transparency. So I think robust stakeholder engagement to make sure everybody has a voice at the table is really important. Publicly sharing the information too. So anytime you start something new, sometimes you need to tweak things. And so sharing that in public settings and allowing for that dialogue, I think has been really helpful. Again, we haven't set a dental DLR in California, but I think just having that stakeholder engagement and transparency has been helpful.
Steve, could I add a little bit to that?
Yes, go ahead.
Yeah, so I agree with everything that Mary said and really appreciated the engagement that DMHC and DOI in California did in bringing everybody together. I think because we were the first state that did this, we didn't quite know what we were doing. And so, one of the things I think looking back, there's probably ways that we could have made the data more accessible. I know DMHC does a really great job of putting together their the slide deck and the charts that you guys have just seen that they share at their regular quarterly meetings. When you actually get down into like, what does this particular plan or this particular product ratio have, it's really hard to access. CDA spends a lot of time and energy every year, and so we have sort of historical information on that, but I don't know that anybody else outside of us and VMHC and maybe some of the plans are doing that. So I do think if you're looking at either a reporting plus, or setting an MLR threshold, I really do think, thinking through how do you want to present the information and what do you want it to do? Again, it's not something that your average consumer is going to be able to access and really do anything with that information. So that might be something to think through. Are you just doing reporting? Are you trying to have it be something that pushes consumer dollars? So how do you want to display that information is definitely something to think about. And I think if we know now if we knew then what we know now, we might have done things a little bit differently.
Okay, any more questions, comments from legislatures?
The only thing I'll add on the point that Brianna just answered is that kind of following, this is Owen from the National Association of Dental Plans, is that experience has been very informative in other states. That in Colorado, we're currently going through the rulemaking process. There was a listening session yesterday on the implementation of the law that passed last year, and Maine recently wrapped up that process and has finalized those requirements. And that built on a lot of the work that was done in California from 2014 on about making that information accessible, but then also knowing that the regulators had kind of a robust framework to jump off on when they're implementing those outlier requirements.
Okay. Okay, we'll make sure that any thoughts, comments, please contact me or the NCOIL staff. I look forward to continued discussion in November, and depend on how things go between now and then, we'll possibly entertain a vote. So next up on the discussion is proposed federal rule dealing with short-term limited duration insurance and accepted benefit coverage. Included in this meeting material is a comment letter that NCOIL submitted to the proposed rule. I'm going to turn it over the committee to Tom, NCOIL CEO, for a few words. Tom, you there?
I am, Mr. Chairman. Thanks very much. So we submitted a comment letter to the concerned agencies on September 11th. This is essentially, without regard to anyone's position substantively on the underlying proposals, this is essentially an attempt at a second bite at the apple by the Biden administration to try and do something that the Obama-Biden administration was not able to do some years ago, back in 2016. And so it would be a significant encroachment into state jurisdiction of insurance, and that was the basis for to our objection. I understand there are some people, reasonable minds can differ perhaps on short-term limited duration insurance, and as well as the other things covered in these plans. But some of the items covered in these plans, frankly, were considered during the ACA, and Congress expressly decided to exempt.
Can't hear you, Tom. Okay. Tom's got some technical difficulties. We'll see what's going on here.
We don't know what happened there. Our line was muted. Will's supposed to be the only one who can mute me. I'm surprised that someone else has stolen that authority. Mary Watanabe, we gave your colleague the ability to share a screen. Did we give her the ability to mute me as well? So at any rate, McCarran-Ferguson, gave Congress the ability to regulate the business of insurance. It didn't give any agencies of the federal government the ability to regulate the business of insurance. So we as NCOIL staff, without wading into the underlying plans themselves, really protected the turf of state regulation of insurance. So that was the basis for our letter. That's all I have, Mr. Chairman.
Thank you, Tom. Okay, now we'll hear from the speakers today. I'll note that other interested parties will be able to speak after our listed speakers. First, we'll hear from Joanne Volk from the Center of Health Insurance Reform. So Joanne, you online?
Yes, I am.
Okay, go right ahead.
Okay, I'm going to share my screen. I have a presentation for all. Here it is. Okay. All right, let me at the beginning here. Okay, hello all. Yes, my name is Joanne Volk. I'm a research professor at the Georgetown University Center on Health Insurance Reforms, and I appreciate the opportunity to share some of our research on short-term plans. We've long done research on these plans and the risks they pose for consumers, and I'm pleased that I can share some of that research with you today. Sorry. Just a little bit about the center before I jump into the plans. We are part of the McCourt School of Public Policy at the Georgetown University, and we're a team of about 15 people who study the legal and policy framework for private health insurance that regulated by the state, as well as federally regulated plans. We track market trends also and publish reports, studies, blog posts, and provide technical assistance to consumer and patient groups and to state officials on private insurance. I'm going to talk about the short-term plans, our research on them, and the benefit limits that they have and the risks for the enrollees. And then I want to share some recent research looking at the sales of limited benefit plans during the public health emergency unwinding. We conducted a secret shopper study earlier this year. So as I'm sure you know, the limited benefit products universe out there is a multitude of products that don't have to comply with the ACA marketplace rules. They include short-term limited duration plans, which I'll call short-term plans, fixed indemnity plans, but also healthcare sharing ministries, which I know you all have looked at before. Importantly, they don't have to comply with key ACA protections, including coverage of the 10 essential health benefits, a prohibition on dollar limits on benefits, requirement to cover pre-existing conditions, requirement to cover people and renew that coverage when it ends, and to meet a minimum loss ratio, which is a measure of how much of a enrollee's premium goes towards healthcare versus overhead costs. So short-term plans is one of those limited benefit plans. When the 2018 rule came out, there were predictions that sellers of the policies would make coverage more robust, to make it seem more comprehensive than it had previously been, but that didn't happen. Instead, it just erased the line between short-term plans and comprehensive coverage, so that it was nearly impossible to distinguish between a plan that stopped just short of 12 months and another that could go for a full year. It often appears cheaper for enrollees who are considering these products, but the gaps and exclusions leave patients with very high out-of-pocket costs. And of course, they're medically underwritten, meaning that applicants with health conditions can be turned down, charged more, or have benefits excluded for their pre-existing conditions. Typically, for all enrollees, these plans exclude key services such as maternity, mental health and substance use disorder treatments, and prescription drugs. Some of these can be added with a costly rider, but they are not in the benefit plan. They can impose dollar limits on benefits. They don't have to be renewed at the plan's end, and they can in fact be rescinded during the policy if a claim is submitted and the insurer can use the substantial documentation of health conditions that it was part of the application process to show that there was some basis for knowing that there was a condition there, even if the enrollee didn't recognize it as such. There are 5 states that have banned rescissions, and I share that here. In a number of areas here, states have gone beyond the federal floor. So I want to talk particularly about this moment, the end of the continuous Medicaid coverage. As you all know, I'm sure the Congress established a continuous Medicaid coverage policy during the COVID public health emergency, in which states were not allowed to do Medicaid redeterminations, and Medicaid enrollment reached a record high. That policy ended in March, and states have now resumed their redeterminations. And by one estimate, more than 15 million people are expected to lose Medicaid coverage before the end of this year. The Affordable Care Act Marketplace is a source of comprehensive affordable coverage for those coming off of Medicaid, but former Medicaid enrollees may not know about this option. There's been a number of studies of deceptive and aggressive marketing tactics used to sell limited benefit products, including short-term plans. We've done some at Georgetown. The Government Accountability Office did a secret shopper study, and others have too. I include links to a lot of this research at the end of my presentation. So we wondered earlier this year, with 15 million people coming off Medicaid, the marketplace opened with a special enrollment period and enhanced premium tax credits, making coverage more affordable for individuals at $10 or less for 4 out of 5 people. We wondered whether or not people that went online to shop for coverage would be directed to the marketplaces and subsidies for which they were eligible. This actually adopts the same process we used in previous Georgetown secret shopper studies. We created 2 profiles for hypothetical consumers losing Medicaid in Texas. They had one who had no pre-existing conditions, and the other who was older and had a pre-existing condition. So when asked, indicated that they took a prescription drug for high cholesterol, but otherwise they were the same. Both females about to lose Medicaid in their state had the same annual income in a household size of 2. So with that income for their household size, we knew that they were eligible for $0 silver plans, including plans with no deductibles, and were also eligible for a marketplace special enrollment period. So with those profiles, we went online to search with Google for terms that people might use when looking for coverage, including health, Obamacare plans and affordable health insurance and healthcare.gov. After entering the information for the consumer profiles on websites that came up with that search, we spoke to 20 sales representatives, 10 for each profile. The results are as follows. In no case was a federal marketplace, healthcare.gov, the top result. It was sites promoting limited benefit products with usually paid advertisements and promoted well above other results. And the first results were often lead generating sites in which you enter your information and calls are generated and outreach from brokers from those sites. One of our consumers received over 100 voicemails in 1 week in response to entering her information into one website. Out of the 20 sales representatives, 11 tried to sell Terry or Lorraine, our consumers, a limited benefit product. At least 2 were fixed indemnity products. The challenge is that at no point was sufficient. Well, in one case was information shared that we could actually determine what the plan was. So it might have been short-term plans, could have been fixed indemnity. In 2 cases, information was shared sufficient to identify them as fixed indemnity plans, but the premiums ranged from $109 to $271, even though they were eligible for a $0 premium plan in the marketplace with a $0 deductible. In no case did a representative direct the shoppers to that plan. For one thing, they misrepresented the products, and I think this is important with short-term plans. I know there's an argument that they are a gap filler, and as long as people understand the limits, they should be entitled to buy what they want to buy. And I think the substantial challenge here is they do not have enough information to understand what they are buying, and often don't find out until too late the benefit limits that there are. So just to describe this process, the brokers or people who reached out to the consumers gave false or deceptive information about the level of coverage these products offered. They made misleading comparisons to major medical plans, and then refused to provide written plan information when asked. That was a part of the protocol, was in all cases to ask for information before making a decision. And it was only shared in one case. And in another case, it was screen shared to look at some quick, like 3 pages of plan documents. They also misrepresented the marketplace plan, saying that the marketplace was closed and not open to enrollment, that subsidies are only available during open enrollment, that they were more costly and had higher deductibles than what could be had with the plans that the brokers were selling. And there was substantial pressure on the shoppers to buy immediately, urging them to commit to the plan over the phone without information about the underlying plan, discouraging them from taking time to look at options or even consider their budget with a premium amount, and telling them that if they came back later, the plans would not be available, they'd fill up or be unavailable. And these high pressure sales tactics were more common among representatives selling limited benefit plans. In terms of the policy implications, despite some enforcement efforts, deceptive marketing of limited benefit products persists, putting millions of people at risk. We, of course, have this proposed rule that you all commented on that would limit short-term plans to 3 months. And states can, of course, go above whatever floor the Fed set, and many have. And I think it's important to raise awareness about marketplace plans and investing in enrollment assistance so people can really take their time and understand their plan options. Again, one of the big risks with short-term plans is you do not get the information about the risks and find out too late what was excluded, or that your coverage can be canceled. And I think while there's a hope and expectation that providing disclosures can help consumers know what they're buying, importantly from the secret shopper study, that moment never happened in that sales transaction, that they could understand exactly what they would have been buying, and substantial pressure to buy on the spot. So I've included links to the secret shopper study here, previous secret shopper studies, and the research that's been done at Georgetown and other centers or researchers about the limits and risks of short-term plans.
Okay.
Happy to take questions.
Okay, we'll wait the questions at the end. Thank you. Next, we'll hear from JP Weisky from the Health Benefits Institute. So, JP,
great.
You there?
Yeah, great. Thank you. Thank you for taking the time, and thank you, NCOIL, for protecting the state's ability to be able to regulate these plans. I think first to note is it is frustrating to conflate short-term limited benefits and healthcare sharing ministries, because the issues are very different between them, and the regulatory solutions on a former regulator are very different as well. So that is a frustrating sort of conversation to be able to have, and that's by design in a lot of folks, and that's concerning. We are very concerned, similar to Georgetown, with the improper marketing. So we've actually done work around this with the NEIC. We are members of the NEIC 171 subgroup, which is dealing with the model regulation around all of these products, except for healthcare sharing ministries. Also, I'm the former chair of the 170, which is the model law related to these. I would note that from a state perspective, states license the insurers, they license the agents. They take the forms and the rates on the insurers, and they review those. They respond to complaints. They actually have data on these plans, and the federal government has none of this. If you read through the rule, it's anecdotes and blog posts around this, and while there are problems and there are concerns, there's a 94% satisfaction rate in the fixed indemnity market. And the thought of the federal government taking these products away is going to be a big problem, I think, for consumers across the country and your consumers as we look at it. I would note that states are continuing to look and gather data on this. Short-term limited duration has a market conduct annual statement process that is currently ongoing. So they're collecting data on the number of plans. I would note the number of individuals who have purchased short-term limited duration plans has plummeted in the last few years. So the sense that there's significant problems is very different. Certainly the issues around marketing, especially around improper marketing of health broadly, part of which has been exacerbated by the federal government's involvement in removing the states from Medicare Advantage marketing issues, is significant. And the NEIC has added a lead generation model into the Unfair Trade Practices Act as a proposal to help deal with this as an issue. We also strongly support disclosure. The simple reality is if an individual misses the open enrollment deadline and does not have a special enrollment period, they literally cannot buy private market coverage except for short-term limited duration coverage in the market. And the idea of a 4-month time limit is going to be extremely problematic. We had some discussions around aligning those incentives around the ACA open enrollment period to ensure consumers have access over the whole time frame that they will be uninsured. But the solution that the federal government has proposed is forcing consumers who miss the open enrollment deadline and do not have an SEP to consistently change plans, have new pre-ex, have new rules, and be subject to underwriting time and again throughout the process. So we're concerned with that. The fixed indemnity market is going to be an existential crisis if it's done as it is written. As Tom indicated, the federal law creates an accepted benefits section, which includes fixed indemnity, which by statutes indicate fixed indemnity is accepted from federal regulation. The rules are counter to the existing statute. We do support broadly the idea that there should be broad consumer disclosure. We support states taking action. I would note, as Joanne had noted, that there are a number of states that have banned short-term plans. There are a number of states that have limited access to short-term plans. They've limited timeframes. They've expanded disclosures. Same thing with fixed indemnity. A number of states, there's a variety of sort of state proposals to look at this. We'd be happy to talk more in detail about that at some point down the road. So the idea that the states are acting and not acting on this is just simply not correct. I would encourage each of your departments, a number of whom have issued letters in opposition to the federal rule, to contact your insurance departments and chat with them about what they're seeing and whether or not there are laws that should be changed in your states. In closing, we again support, there are very different solutions around short-term and fixed indemnity insofar as marketing issues go. And I would also note, a secret shopper survey in one state speaking to sales representatives and not agents creates an issue, right? I acknowledge the issues that Joanne has highlighted, and it comports with others that have seen similar issues when you go through sales representatives rather than using licensed agents. And, I think that has been part of the marketing problem, is the use of non-licensed agents, which has been exacerbated by the lack of federal action on a number of things. So states have been forced to act and are trying to figure it out without federal help on a number of these. So would be happy to answer any questions, and thank you for your time.
Okay. Do we have any other interested parties like to talk about this issue before we open it up to legislatures?
Yes, this is Michael Hickey.
Sorry.
Well,
go ahead.
You go ahead first. Go ahead.
Ronell Nolan, President, Health Agents for America. Couple of concerns about the Georgetown report. Number one, we know that Congressman Smith from Missouri just came out and said 1.6 million folks would be affected if the short-term medical plans were taken away. And I agree about 20 representatives not being a good way to determine what's actually going on in the market. The short-term medical plays a huge role for those not only that are not during an SEP, but those that do not get a tax credit. So if they do not get a tax credit, they can, choose the plan they want that has, all the bells and whistles that maybe it doesn't have that a marketplace plan has, but it's their choice. We all know the ACA is not affordable. Premiums are not affordable. If you look at the premiums for an individual without a tax subsidy, you would probably be blown away. People can't afford it. So they play a role. We appreciate, transparency as agents. And I just wanted to say those couple of things, and I appreciate it.
Okay. Was it Michael next?
Yes, thank you. It was Michael Hickey with AFLAC. I wanted to thank NCOIL for the letter that was sent to the agencies. It's great when we hear from the state legislatures. I also want to thank JP. He actually said a lot of what I wanted to say. And part of our problem is at AFLAC, we don't offer short-term limited duration policies. We offer fixed indemnity plans, hospital indemnity, cancer, specified disease, and they often get lumped together and considered short-term limited duration. And the way we look at this federal rule right now, it would put a lot of our products out of business. Gets into tax problems that I'm not going to raise here because this isn't the forum, but I did want to thank JP and Tom for the comments from NCOIL and the industry. So thank you.
Anybody else before we go to legislatures?
Can I just respond? I do want to point out that the people that were shopping, the tax credits at this moment are available to all. There is no longer a 400% poverty cutoff. And the particular consumers we were using were eligible for the greatest subsidies for their premiums and out-of-pocket costs. So they would have gotten a plan with a $0 deductible, 94% AV coverage, $0 premium. And I should add too that they all seem to be being sold through an association. There was a reference to a one-time fee that would lock in your rates for 3 years if you paid it. So we took that to be a reference to association plans. And I know, JP, you know the challenges of capturing sale through associations for state regulators and getting that count in the MCAS at NAIC. This is not to disparage reputable brokers, but we took the path that I think most people would take to shop for anything, health insurance, TV, whatever it is, we go to Google. And we even used healthcare.gov, and it didn't come up as the first option. So I'm just trying to make folks aware of what many people will use as their shopping mechanism will unfortunately not only not lead them to the optimal plan in the marketplace with $0 premium and $0 deductible, it will mischaracterize what that coverage is and mischaracterize the coverage that they're being sold.
Anybody else? We open up the legislatures.
Chairman, this is Miranda Motter with AHIP. Just really quick, not to belabor, but I would just reiterate a couple of the things that JP and others said, just in terms of how important fixed indemnity products are. We know that Americans need to be protected from the few bad actors who certainly commit fraud and abuse that we have heard, but we want to be really clear and make sure that we don't throw the baby out with the bathwater, because we do know that Americans, do agree that these kinds of plans are an important choice for them. And those Americans that do have these plans are satisfied with that coverage. And so just want to ensure that the personal choice, control, financial security through these products remain. So just wanted to quickly say that. Thank you.
Okay. Anybody else?
Chairman Westfall, John Ashvilder with State Farm. Appreciate the NCOIL letter and the comment from NCOIL on this matter. We agree with the statements from JP Weskey and from AFLAC and others related to the fixed indemnity issue. It is important and very important that it stays in line with the federal statute, which actually exempts these products. So would appreciate the continued focus of the states in terms of that exemption and protection of a very important and quite frankly, essential policy in the fixed indemnity products. Appreciate the opportunity to comment. Thank you.
Thank you. Anybody else? Okay, do we have any legislators, any comments or questions for our speakers, our guests? Anybody? Okay. Well, I want to thank everyone today. Be sure to submit any thoughts or comments on this issue. I look forward to discussing this at our meeting in DC or during our fly-in and later this month, and then in November in Columbus. I want to thank all our presenters today and all the people. We have any other business before the committee? If not, I need a motion to adjourn.
So moved.
Second?
Second.
Second. All in favor say aye.
Aye.
All opposed? Nay. The ayes do have, we are adjourned. We'll hopefully see some of you at the fly-in in DC and then in Columbus in November. Thanks, everybody.
Thanks, everybody. Have a great weekend.
Thank you.
Thank you. Take care, everyone.